Hi everyone, Dr. Madan Pandian here from Pondicherry. Today we are going to discuss a case of carpal tunnel syndrome and its treatment. A 56-year-old non-diabetic gentleman, a cook by occupation, presenting with 2 years history of chronic right wrist pain along with severe pain, particularly at night, involving the radial 3.5 fingers. Pain does increase with his cooking activities like cutting vegetables and making samosas and is relieved by using splints. In spite of being on splints, the patient continued to have pain. Hence, we decided to evaluate further and possibly do an intervention. On clinical examination, the right hand and the wrist was looking a little bit shiny. The classical ape thumb deformity was present because of the atrophy of the thenar eminence. The following clinical tests were performed: the phalanx test, the reverse phalanx test, the Durkheim's test or the carpal compression test, and the Tinel sign, all of which were positive in this particular patient. Typically, this patient had a bilateral carpal tunnel syndrome. The right side was more than the left side, both electrodiagnostically, clinically, as well as by ultrasound examination. We decided to evaluate this patient. The fasting blood sugar was 110, the thyroid profile was normal. A nerve conduction study revealed a severe carpal tunnel syndrome on the right upper limb. A high resolution ultrasonography was performed prior to the intervention. Venture into performing any intervention, we need to understand what are all the differential diagnoses of carpal tunnel syndrome. Always rule out a cervical radiculopathy by performing a Sperling's maneuver. Isolated median nerve neuropathy, particularly at the forearm, maybe in patients with pronated teres syndrome, again needs to be ruled out. A peripheral neuropathy, which can be ruled out easily by your nerve conduction study as well as looking at the clinical presentation. Usually it presents as a glove and stocking fashion, and rarely it can be due to a vascular etiology, which can very well be excluded by your high resolution ultrasonography with Doppler examination. As pain physicians, we need to understand why there is a need for ultrasound examination prior to any intervention, be it a percutaneous intervention or a surgery. In early stages of carpal tunnel syndrome, there are no morphological changes, but later on histology, there is a progressive demyelination and fibrosclerosis. It causes sensory as well as motor deficit. Usually, there will be a change in caliber and echo texture, change in shape as well in ultrasound examination. There is a swollen nerve, proximal as well as distal. There can be a bifid or a trifid nerve. There can be a persistent median artery or an abnormalities of the transverse carpal ligament. Always look for structures within the tunnel. There can be a tenosynovitis or a small ganglion, which can be a reason for the carpal tunnel syndrome. Try to keep the patient's limb fully supinated with the palm facing upwards. Keep an IV bottle or a gel bottle underneath the wrist to avoid any amount of anisotropy while doing the examination. Try to move the fingers a little bit while doing the examination and try to see all the flexor tendons and structures within the carpal tunnel. The success of any carpal tunnel intervention lies with the best ergonomics possible for the patient as well as the machine. Keep the machine just opposite to you with the patient sitting from the sides and keeping the limb fully supinated with the palm facing upwards and an IV bottle underneath. With the best of ergonomics of the patient and the machine, you will get a turtle-shaped image. The scaphoid tubercle which is lying on the radial side, the pisiform which is on the medial side. You will have the flexor retinaculum which is bridging between the pisiform and the scaphoid tubercle. The tendon of flexor carpi radialis which is lying above the scaphoid tubercle. There are 9 tendons within the carpal tunnel. The 4 digital slips of the flexor digitorum superficialis, the 4 slips of the tendon of flexor digitorum profundus, and there is a hyperechoic tendon which is the flexor pollicis longus. The most important structure is the bifid median nerve which is lying within the carpal tunnel here, and there is a small persistent median artery just beneath the flexor retinaculum. One structure of importance outside the flexor retinaculum is the ulnar artery, which is an important structure which should not be breached while needling. Also of importance is the ulnar nerve, which is again outside the flexor retinaculum, Cross-sectional area of the median nerve was measured and it was around 24.52 millimeters square. More than 12 millimeters square generally is indicative of a carpal tunnel syndrome. Always look a little bit to and fro. Try to look for other abnormalities within the carpal tunnel. Here we have a bifid median nerve and there is a persistent median artery which is thrombosed. Generally, examination of the median nerve at the wrist is done at axial views. Maybe it is not enough. Always look for the long axis view of the median nerve. This is the long axis view of the median nerve. There is this site of compression, which is the cause for the carpal tunnel features. This is the distal end of the median nerve, which is looking a little dilated. And this is the proximal end again, which is looking a little thickened. A typical hourglass pattern of the compressed median nerve. After a thorough evaluation with ultrasonography and neurodiagnostic methods, we move on to the options for interventions. Steroids provides very little pain relief for a very short time. Dextrose, 5% dextrose can be used perineurally for 2 to 3 sittings. Botulinum injections can be given at the muscle level. PRP injections are an emerging option for interventional methods. There are always something called percutaneous release techniques, which are again emerging methods for intervention in carpal tunnel syndrome. Here, we have chosen to give 5% dextrose. After sterile preparation of the injection site and the linear transducer, a medial to lateral needling is done in an in-plane technique. A 26 gauge 1.5 inches needle is inserted from the ulnar aspect of the distal carpal tunnel. 1 ml of 2% lignocaine is infiltrated and the needle is advanced to pierce the flexor retinaculum. Care is taken to avoid the ulnar artery and the ulnar nerve and of course the median nerve. 4 ml of 5% dextrose is injected above the median nerve and 4 ml of dextrose is injected below the median nerve as well. Try to hydrodissect the median nerve from the retinaculum and the surrounding flexor tendons within the carpal tunnel. After adequate injection of 5% dextrose, a gentle needle fenestration of the flexor retinaculum is performed with a 22 gauge needle with utmost care to avoid any injury to the median nerve. 2 ml of 5% dextrose is injected perineurally along the long axis of the nerve. After the intervention, an ice pack is applied at the injection site. This is how exactly you perform a perineural injection of 5% dextrose. This is the long axis of the median nerve, which is obtained by keeping the transducer along the sagittal plane. Inject with a 26 gauge needle around 2 ml of 5% dextrose outside the epineurium. Care should be taken not to damage the median nerve. Also, you could perform a radial side injection where you can have a small aberrant artery like this, the FCR tendon, the flexor carpi radialis tendon, which can be injured and which can present as a post-procedure soreness of the thumb, or there can be a palmar cutaneous branch which is lying on the radial side of the flexor retinaculum. All these three structures needs to be taken care while you do a radial side injection. After the intervention, give enough of ice pack at the needle site. Rest and splints to be continued for the next 1 week with doses of paracetamol if required. Review the patient after a 5-day interval after the procedure. Two most important things. Please do not use steroids. Even if it is for a short-term relief, try to use 5% dextrose. Maybe 2 to 3 sittings may be required, but it provides the most important long-term relief and regeneration of the median nerve. Secondly, avoid the vital structures while performing the procedure. This particular patient had 80% pain relief after 2 sessions of 5% dextrose injection over a span of 2 months. He scheduled for one more session for better pain relief. Thank you.